So welcome everybody. I'm here in spirit, not in voice. So Dr. Rodriguez, could you call the roll?
Sure, I will do that. We'll go ahead and get the roll call for today's meeting. Dr. Curran, Mr. Hoppert, myself, I'm present. Major General Cardin, Dr. Cheek,
Present.
Dr. Coles,
Present.
Dr. Mercer, Dr. Shin, Dr. White.
Present.
Thank you. That's
Can you hear me?
Yes, we can.
Great, thanks.
That's a roll call. You all also will move on to the minutes. We have the minutes submitted to you all by email. You've had a chance to review. If there's no discussion, I would like to submit those for approval. If I could get a motion.
So moved. This is
This
Dr.
Dr.
Cheek.
Thank you. Dr. Cheek, second. I take it that was,
Second.
Dr. Coles.
oh, thank you. All in favor?
Aye.
Aye. Aye.
Thank you. Dr. Curran, the roll call and the minutes have been approved. I'll pass it back on to you, sir. You're on mute.
Thanks. I guess we're ready for new business, Dr. Toomey.
Thank you very much. As we often do, we are starting off with some epidemiology updates, which we are really very excited to present because there's some unusual trends that we're seeing right now. But before Dr. Drenzig starts, I want to say, as you all are well aware, for the last 2.5 years, we've been working almost exclusively on COVID. And the fact we've been able to jump right in and address everything from hepatitis of unknown etiology in children to monkeypox, and also active surveillance looking at avian influenza potential exposures in workers is an example of how public health has to be agile, has to be able to respond at a moment's notice to any public health threat. And I'm just very pleased to see how quickly and with the skill and agility that we did it, we have jumped right in to look at these issues. And I think you'll hear that in Dr. Drenzig's presentation. I'm turning it over to you, Dr. Drenzig.
Great. Thanks so much, Dr. Toomey. I appreciate that. Members of the board, it's a great pleasure to be with you again this afternoon. This particular presentation really is essentially a tour through some of the more interesting and new infectious disease issues that we've been dealing with over the last few weeks, including our old friend COVID as well. So can I have the next slide, please? As you've heard me say so many times before, and as Dr. Toomey alluded to in her opening remarks, for us in public health, we're always on the lookout because infectious diseases are always changing. They're always unpredictable. Especially ones that have zoonotic origins, which many of them do that we're dealing with, especially the ones we've been dealing with over the last few years. However, for us in public health, our primary mission is to ensure that we have an adequate and robust infrastructure to conduct surveillance for diseases and epidemiologic characterization and investigation, because that information, again, allows us to tailor our control measures, to tailor our response, to hit the target of control, if you will. All of it is founded on epidemiology. And so I'm going to take just a few minutes. It seems long because we're going to go through all of these subject matters, but we're going to take a quick tour and illustrate these points about how having ongoing surveillance and learning more information as we go allow us to control and prevent infectious diseases of interest that come up no matter when they do come up. So we're going to look at COVID. In the landscape of COVID that's going on recently, monkeypox outbreak that's going on globally right now, a little bit about avian influenza, and a little bit of an update about the acute hepatitis of unknown etiology in children that we talked about last time we had the pleasure of being together. So first and our usual first, let's take a real quick look at COVID and see what's been going on recently. So as you know, we've been experiencing our sixth pandemic wave over the last few months. This is really can be referred to as the Omicron BA.2 wave. Essentially, this particular wave has been in magnitude, sort of much less than we saw with the original Omicron. And what's been going on recently is really rather interesting as well, because if you look at COVID numbers nationally, here in the US, most of our COVID surveillance numbers for the last couple of weeks have been relatively flat. They're not increasing greatly. They're not really decreasing greatly either, even though we are still seeing increases in the proportion of cases that are due to the subvariant BA.2.121. This has been the predominant one now for many weeks and is now up to about over 60% of all circulating virus in our country. So we're seeing that these flat case numbers, hospitalizations are starting to rise a little bit, deaths are down just a little bit, but again, nothing is, sort of these huge accelerations or decelerations. However, there's still some areas of the country that are very recently experiencing what we would characterize as a surge or really kind of a large increase, primarily in kind of the Middle West, areas like Oklahoma, Wyoming, the Dakotas, Arkansas, and some areas of the southern US as well. So some of these places in the US are experiencing, sort of doubling in case numbers, whereas everyone else is really pretty flat. And if you look at the CDC kind of community transmission levels, that's increasing in a lot of places as well. What about here? For us in Georgia, we're seeing some slight increases in our case numbers and in most of our surveillance indicators, about 20% or so in the last week. And again, not huge, but slow and steady. It's been similar, for many, many weeks. We're definitely not declining, but we're not, sort of surging like they are, for example, in Wyoming. So what's really going on? Is this BA.2 wave actually receding here in the US? Are we actually experiencing, all these waves? They come up, they come down at some point. Well, we could be, but I think there's a little bit more going on here as well. I think there's two things at play. And one is that I think that the magnitude of this BA.2 wave is really, even to this day, sort of higher than what our numbers show across the nation, because there's a lot of impact of individuals that take COVID tests at home. And these are not kind of counted in all of the usual surveillance numbers. This is not new. This is something that's been going on, kind of throughout the pandemic. But, and again, it's a contributor to the fact that some of these numbers, again, maybe just be capturing a proportion of what's going on, but still capturing the trends, still capturing essentially where, we need to draw attention to and what prevention measures are needed. And the other thing that I think might be going on and might be starting to contribute to some of these changes is that even though numbers are flat, again, we're starting to see some increases in the proportion of the variants BA.4 and 5. They caused a lot of surges in other countries, like in South Africa and in Portugal several months ago. They're starting to increase in the US. As a matter of fact, even over the last couple of weeks, CDC wasn't even really breaking out their proportion a few weeks ago. And as of last week and this week, we're already up to about 20% nationally of all cases are due to BA.5 and BA.4. So that's new. And in that case, that might be contributing to some of these surges in some areas. And it's just something for us to keep an eye on, as we've mentioned many times before, that these variants will come and will go and will and potentially can impact these numbers. So no matter what, Again, I think caution and prevention are always prudent, obviously including vaccination and boosters for those that are eligible and for those that still need to be boosted. So let's just break down our surveillance indicators like we do really quickly. We'll take a look at the case numbers. And here we go. So here we are in Georgia. Here is our BA2 wave. And as you can see, it's obviously, much, much smaller than the Omicron BA1 wave earlier in the year. But we're starting to see again, kind of this slow, steady increase, not huge, but slow, steady increase, again, this 20% increase or so. And again, for us in Georgia, the proportion of cases that are due to BA2121 is about 66%, just a tiny bit higher than nationally. And our proportion of this BA4 and 5 is very similar to the national levels as well. For us in the Southeast, it's about 15% BA5 and about 6% BA4. So whether this is contributing at all to this increase, we'll have to keep an eye on that as well. Next slide, please. So when we look at hospitalizations here in Georgia, again, the picture looks the same. And again, our hospitalization numbers are increasing just a little bit, kind of proportional to our case numbers, about 17% in the last week. But the numbers are dramatically lower than that they have really almost ever been during the pandemic, prior to Delta wave, as a matter of fact. So we're about, 88% lower in our hospitalization numbers than we were even during Omicron. And again, this is a strong testament to really the impact of vaccination and boosters in preventing severe outcomes, no matter if we, again, are facing a new subvariant or a different variant even, no matter where we are. Again, vaccines are still holding very, very well, against hospitalizations and deaths. So let's take a look at our deaths next. So this is our Georgia death epi curve. And as you can see, we are again have decreased greatly in number and in magnitude from the Omicron wave. But again, we're also kind of just steadying over the last few weeks. The numbers are quite low. Our death numbers are about as low as they were, similar that you just saw with hospitalizations to even before Delta. So again, we're glad to see that hospitalizations and deaths are definitely again, much, much lower than they have been. Another strong testament to the impact of vaccination and boosters. But again, as we're looking, and we still look at these people that have been hospitalized and who also ones who have fatal COVID infections are indeed, for the vast majority, unvaccinated or under-vaccinated. Next slide, please. Again, just wanted to hit that point one more time. You've seen these graphs before. Again, really just want to show you, and again, these are really by counts that we're looking at. Again, if you look at the red lines, these are individuals that have had a primary vaccine series only. The black lines are unvaccinated, and the gray lines are those that have had a primary series and booster dose or doses as appropriate. So really, if you just sort of take a look, even just visually, upper right is cases, lower left is hospitalizations, lower right is deaths. Clearly the unvaccinated, comprise over the course of the pandemic, the vast majority of cases, hospitalizations, and deaths. Those that have had a primary series have made a strong impact in reducing those numbers, but those with a booster are even much, much lower. But if you look at even kind of the far right of all of these graphs, the recent, we're really dealing with a lot lower, magnitude than we have been throughout the whole pandemic, whether it comes to, cases, hospitalizations and deaths. And again, for me, is really underscores the same point that I've made so many times for us all, is that the importance of vaccination and boostering for those that still need it. So next slide, please. Thanks. So again, no matter what, and you'll see this theme again in the other subjects that we're going to be talking about, we cannot be complacent SARS-CoV-2 is still with us. It's proven very adept at changing, and whether we're beginning to experience here in this country the advent of perhaps even a replacement or an outcompeting of BA2 1.1 with BA4 and 5, I don't know. But if that's the case, this particular virus has shown us many, many times before that it's capable of surprising us, changing. But no matter what, again, the normal and traditional prevention measures that we've talked about all along remain prudent and remain necessary. Vaccination, boosters, surveillance, infrastructure, and testing, ensuring that people do get tested and follow the usual recommendations for isolation, quarantine, to try to prevent onward spread. No matter what, we'll, whatever wave we're controlling or the ones that we deal with in the future, whether it's BA4 and 5, again, those measures will never change. So wanted to give you a highlight and kind of thinking about what's next in COVID. We'll see, but get your boosters, that's for sure. Next slide, please. So now we're going to slide to on our tour. We've gone from COVID. Now let's talk a little bit about this monkeypox outbreaks that's going on globally. Really fascinating and really, again, unpredictable. People think, for example, that this monkeypox outbreak is something that is novel and brand new. Well, monkeypox itself is not new at all. We have a lot of experience with it, but it's a rare disease that has been primarily found in Central and West Africa for many decades. It was found in 1958, and it's caused, the disease is caused by the virus called monkeypox virus. It's a similar pox virus to smallpox. Again, so it's been endemic in Central and West Africa for a long time, with again sporadic outbreaks in those places. But again, it is a zoonotic disease and that has an animal reservoir that's really not very well characterized. However, usually when we've seen monkeypox cases around the globe before, it's normally been associated with international travel. Somebody that's been to Central or West Africa and has traveled to either, again, here in the US or in other countries where it is not endemic. And so it's kind of sporadic cases, not huge outbreaks. Although we did have an outbreak here in the US in 2003 that was associated with animals that were imported from Central and West Africa. Again, they were small rodents that were imported and ended up infecting pet prairie dogs. You may remember this. This was some time ago, but there were actually 47 cases of monkeypox then in the Midwest. So we've had some experience with outbreaks, but what's going on now globally is really unusual. So it's not just the sporadic 1-2 cases here and there associated with travel or even, sort of known animal exposures. Here globally, CDC and the World Health Organization are monitoring and tracking more than 1,500 monkeypox cases in, I think today it's actually 35 countries instead of 33. So many places. And again, and these particular cases are very interesting because they do not have, sort of a known in all situations history of traveling to Central or West Africa. These are places that don't have endemic monkeypox, and the people, it's not like all 1,500 of these people have been to Nigeria, for example, where there has been a large monkeypox outbreak since 2017. These are popping up all over, in kind of in a simultaneous way, or at least chronologically close together, close in place and in time around the globe, which is really unusual. I haven't seen a monkeypox outbreak look like this before. This particular disease, again, there have been no deaths reported in this particular outbreak. Here in the US, we've got about 65 cases in 18 different states now. We have 2 here in Georgia. And epidemiologically, again, normally, as I say, the epi kind of, informs our control measures. We used to think of monkeypox as something that is travel associated, that we have to think about education and awareness about travelers. And then spread, from one person to another. But in this situation, again, this is not travel associated in all cases. It's really the epidemiology is pointing to, sort of person to person, close person to person spread. But again, not like COVID, not like we're dealing with, sort of respiratory or airborne transmission here. We know a lot about how monkeypox is transmitted. And again, the epidemiology, as we look deeper, will kind of give us a clue as to how these cases were transmitted from one person to the other. And it allows us to make some decisions about how we're going to advise, educate, and prevent the spread. So let's look at the next slide, and let's look at the epidemiology in a little more detail. So let's look at the US picture first. And again, we're seeing a similar picture in other parts of the globe as well. So for us in the US, and again, this information is primarily based on information, probably from a week ago or so, hasn't changed much. But again, some of the newer cases are not necessarily included in all of these. But if we look at the cases as a whole, let's just again snapshot this and say, in the US, all of these monkeypox cases are occurring among adults. The median age is 38 years. The range is about 23 to 76 years of age. Most by far are male. Most self-identify as MSM. And again, many of our US monkeypox cases have reported international travel, but they have not reported travel to Central or West Africa or in areas where monkeypox is endemic. They may have reported travel to areas where there are other monkeypox cases. Again, we're dealing with, a number of countries now that have monkeypox cases. And the main, risk factor, sort of reported among these cases was looking at very close physical contact with somebody that had lesions characteristic of monkeypox. The other thing that's really been interesting about the epidemiology of this particular outbreak that's, kind of different than what we normally see is that many of our monkeypox cases here in the US have also had co-infections with other sexually transmitted infections, such as chlamydia, syphilis, or herpes. And so again, the reason this is important is also because when we're thinking about awareness and clinical awareness, the fact that an individual may have been diagnosed with syphilis, for example, may not necessarily exclude the possibility that they have a co-infection with monkeypox if they have, sort of this sort of picture and link, perhaps to an individual that is a known case or in an area where there have been known cases as well. Normally, we know a lot about the clinical picture of monkeypox, has a very characteristic rash, and it usually has a pretty characteristic clinical, sort of picture from start to finish, where there's a fever and lymphadenopathy and, prodromal symptoms to begin with. But in this particular outbreak, I think it's been really interesting that many of these cases have presented in an atypical way, without fever, without lymphadenopathy, and that the rashes looked a little bit different. And it still has sort of the characteristic appearance, but it's, again, much fewer, kind of fewer in number, and also beginning perhaps, starting perhaps in the genital or perianal region. So in these situations, we're really seeing a little bit of clinical difference here. And I think that also, sort of allows us to better detect cases. And as we find out more and more about, who's most at risk, it allows us, again, to have this scientific foundation for how we're going to educate about prevention and control. Next slide, please. So this is, again, just really briefly, I don't want to get a whole lot of detail into a lot of the monkeypox rash pictures, but the pictures on the top are the kind of traditional monkeypox cases that have been seen in areas of the world where it's endemic and it's, kind of very disseminated, kind of in this centrifugal fashion, this very deep-seated, well-circumscribed, even umbilicated rash. But, what we've been seeing recently, and these are pictures that CDC presented yesterday that really essentially show it can look a little different. There's not as many. It can be flat. It can be macular. And again, they may not be, kind of as characteristic, and they kind of go through the stages in a much more rapid fashion. Next slide, please. So what are we, going to do about kind of our response to monkeypox from a public health and from a clinical standpoint? Because you need both sides in order to detect cases and to stop spread. And it all goes back to what Dr. Toomey said in the very beginning, and that is the kind of tried and true public health interventions that we used for COVID, that we used for smallpox, that we used for STDs, no matter, kind of for TB. What we use is exactly what we're doing, here in monkeypox. And that is identifying cases based on, again, having, maybe knowing about the epidemiology, knowing about this slightly different clinical picture, isolating cases so that they, again, are not spreading to others, doing contact tracing for individuals that have been exposed to these, to these direct lesions, conducting a risk assessment as to, how likely are they to have been exposed, monitoring contacts for the development of symptoms, and using medical countermeasures if appropriate, like vaccination. They actually use smallpox vaccine under an investigational use, if appropriate and within the right time. So again, that should all sound familiar to, kind of how we approach many infectious diseases. And that's because that's how we eradicated smallpox in the first place anyway. So again, that should seem familiar to us. But one of the things we need to do is also, as I mentioned before, not just the public health response, but the clinical response, and say, like, be aware as a clinician, please be aware that this is how we might be seeing these patients present. Raise index of suspicion that there might be co-infections. If you have a concern about a rash that looks potentially consistent, or maybe even doesn't look all that consistent, but maybe the epi link looks consistent, call us in public health at 1-866-PUB-HEALTH, like normal. We will consult with you. We have medical epidemiologists on call 24/7. We will consult, and we will arrange for testing at the Georgia Public Health Laboratory. That's where testing must take place right now. In the meantime, and CDC can do sequencing and can do further confirmatory testing as well. But in kind of in summary, when we're thinking about this, and we're still much more to learn, is, again, we use our epidemiologic data and our epidemiologic picture to help identify cases and drive prevention measures. But again, think about this. I just want to be clear that, anyone could potentially get and spread monkeypox, but we really do want to focus in, essentially on routes of transmission and the epidemiology as we move forward in learning more about this and be able to stop it and spread it like we have with many other infectious diseases. Okay, those were the two longer ones. I got two short ones to go through. Next slide, please. And we'll do these really quick. I just wanted to give you two updates about two other infectious disease situations that we talked about a month or so ago. And one is this particular year, amongst everything else that's going on, has been a huge year for avian influenza in bird populations. And again, our U.S. Department of Agriculture has a really robust surveillance program that is used to detect highly pathogenic avian influenza in both wild and in commercial poultry flocks, whether they be commercial or backyard poultry flocks as well. HPAI, or avian influenza H5N1, is carried by wild migratory birds, and they can infect commercial flocks and backyard flocks as well. And this is a huge economic impact, primarily because it results in depopulation of these birds. And if you look at this slide, look at how many detections of HPAI there have been this year. There's been 186 commercial flocks, 183 backyard flocks, and 4 million birds were impacted, meaning that they had to be depopulated. So this is a huge economic impact. But for us in public health, we also have another, there's another strong reason why we're so interested, and that is because anytime an animal flu virus has the potential to cross over into humans and infect them, that can indeed result in further changes that result in a novel virus and perhaps a pandemic. So for us in public health, as much, certainly we are very concerned about the economic impact of avian flu. But for us, we want to be sure that if there's a potential human impact, we can identify it right away so that it doesn't have an individual that is infected with avian influenza, a person that's infected with it doesn't have the opportunity to, for the virus to evolve and potentially spread to others. So next slide, please. So we actually have found some avian influenza HPAI in Georgia recently in a commercial, in a backyard flock, not a commercial flock. This was a backyard poultry flock. It had other birds in it as well, all different kinds of birds in southeastern Georgia. And again, so what happens in this situation when it's found in a backyard flock, essentially the agriculture response is really to try to, again, depopulate the birds so that they don't spread, it doesn't spread further. This really impacts them and kills birds. It makes them very sick. So they get depopulated and then they do surveillance, in a control zone around these farms. So next slide, please. So for us in Georgia, when they find something like this, we've had a really long-standing, established partnerships with a number of different agencies here in Georgia and have very strong HPAI plans. So it's all laid out as to exactly what happens in the Department of Agriculture, in our Georgia Poultry Laboratory, industry, our universities, and federal ag partners as well. So they go ahead and look at surveillance among birds. And for us in public health, our role is primarily to monitor any humans that were in contact with these birds to make sure that they haven't been infected with a potential avian flu strain. So we did that. We actually set up a monitoring system. We've used it many, many times for many other things as well. We just modify it. It's an electronic system. And we monitored about 20 persons that were involved in this situation. All remained healthy. None developed influenza-like illness. None developed flu. And if need be, we would have had them tested at our Georgia Public Health Lab as well. So more to come there, but thinking about the potential for infectious disease change and for us in public health of using the epidemiology here to try to prevent the spread. Next slide. We're getting near the end here. Last but not least, one quick update about the hepatitis in children. So again, this particular situation has been evolving really very slowly and has been going on for a number of months. As you recall from our previous discussion about this, it all began in October of 2021, where there were 9 children in Alabama that were diagnosed with severe acute hepatitis of unknown etiology, several of whom needed liver transplants. But now, as of June 8th, this past week, we have a total of 275 children here in the US that have had acute hepatitis of unknown etiology, and it's in 39 different states. We have less than 10 of them here in Georgia. And in total, out of those 275, there have been 9 children that have actually died. And if you look at the epidemiology of what's going on with this population of kids, almost all of them were hospitalized. 15% needed liver transplants, and the median age is 2 years old. So very young children. None of them had hepatitis viruses, and close to half of them had evidence of an adenovirus infection, adenovirus type 41, which is not known to cause hepatitis in children. It usually causes some GI illness. And if you look at around the globe, interestingly, there's about 700 cases suspect around in 34 other countries as well. So again, these infectious disease situations, again, have no borders either. We're dealing with monkeypox, we're thinking about hepatitis. Look at how broad these situations are. And so what's really going on? Next slide, please. It's still unknown. The cause of hepatitis in these children still remains, definitively unknown. Evidence is accumulating that an adenovirus infection is playing a role, but there may be other cofactors too. CDC is casting a really wide net to look at what potentially could be involved, other cofactors, previous infections. Have any of them had COVID at the same time, other medications, and they're beginning an epidemiologic study nationwide. Interestingly, there was just an MMWR that is just being published even as we speak. I think it came out at 1:00 today. One of the main questions was in this whole situation and was, hepatitis in children, without a specific etiology, if it's not one of the usual hepatitis viruses, is not really reportable. We don't really have a good baseline as to, is this really way higher than it should be? That's the true mark of an outbreak. And again, CDC is trying to publish some information, trying to figure out, is this really way above the background rate? And if so, where is adenovirus and where does it fall here? Are we really just learning that adenovirus could be and may have always been a cause of acute hepatitis in children, but we didn't realize it? Or is it really something else? Is there really a factor in the COVID landscape? Is there something else going on? And hopefully these epidemiologic studies that are ongoing right now, and many of our children's hospitals here in Atlanta are participating as well, will be able to elucidate that as we're thinking about, same scenario, finding cases, asking clinicians to be alert, call public health, find cases, identify, characterize the epidemiology so that we can figure out what's going on, so that we can prevent this from happening to others if at all possible. So more to come with this one too. And I swear to you, this is the last slide. Yeah, closing comments. Thank you for your patience with me. Again, infectious diseases are ever changing, unpredictable. It's what makes my job exciting every day. And I know that, again, we have the tools in public health to be able to face no matter what comes to us, no matter what comes our way. And that is surveillance, epidemiologic investigation with the grand support of a laboratory as well. And I want to thank very much our Georgia Public Health Laboratory partners for all of their work and all of their support in all of this, because that's what drives primarily our prevention measures. So now I'm out of breath. Thank you.
Sherry, that was very informative. We appreciate your knowledge and passion. I wish you didn't have so much to be excited about.
Me too.
Are there any other comments or questions? If not, I guess we'll move on to infant formula.
Thank you so much. Good afternoon, Board Chair, Dean Curran, the board, Dr. Toomey, and others. My name is Latoya Osmani, and I am the Director of the Division of Health Promotion. And I have with me today Sean Mack, the WIC Director. And we are glad to be here with you today and appreciate the opportunity to provide an update on the infant formula shortage. As a part of today's presentation, we will provide a very brief overview of the shortage, and we will also provide an overview of the impact the shortage has had on the Georgia WIC program and the program's response to the shortage. And finally, we will provide important reminders for everyone to keep in mind as related to the shortage. I'm turning it over to you now to Sean Mack, WIC Director. Thank you.
Thank you, Latoya. Good afternoon, board. Excuse me. So as Latoya said, we wanted to give a brief overview of the landscape prior to February 2022. Next slide. Thank you. COVID-19 provided some immediate supply chain issues, as we were all aware of during the onset of the pandemic. Infant formula was included in those supply chain issues. The WIC program for Georgia requested COVID-19 waivers as part of the Families First Act. These are food package substitutions at the grocery stores and minimum stocking requirements, a waiver of the requirement that stores had to have certain items in the stores because of these supply chain issues. Next slide. And then we come forward to the Abbott recall. As of February 2022, Abbott is one of the 3 major manufacturers of infant formula in the United States and controls almost half of the market, approximately 48%. Recall was issued on February 17, 2022. It was a voluntary recall by Abbott, and it included the formulas Similac, Alimentum, and Elecare. Recall came after 5 children were diagnosed with bacterial infections after consuming products. and the recall caused the shutdown of their Sturgis, Michigan facility. After that, Abbott only had 2 facilities that remained operational after that shutdown. And considering their impact on the market, that was a considerable, sizable impact to the amount of formula being made available in the United States. Next slide. One thing we definitely want to make sure everyone is aware of is that in the program, WIC has an infant formula contract. All WIC programs per USDA federal regulations must contract with an infant formula manufacturer to obtain a rebate to lessen the program's costs. Georgia WIC contracts with Mead Johnson Nutrition, which produces Enfamil, and not Abbott. No Enfamil products were recalled. Next slide. So the formula shortage impact on Georgia WIC, initially, we were not heavily impacted. There were some, the Alimentum and the Elecare did cause some impacts to some of our participants who have special nutritional needs, and we initiated strategies to address those formula needs. The shortage has worsened, impacting all formula supplies across all brands, all infants, and not just WIC participants. As it has stretched out over several months, it has begun affecting all brands of formula and all infants. Next slide. So let me talk about Georgia's response to the formula shortage. And, pardon me. We requested waivers that were presented by the USDA. We requested waivers for vendor exchanges, which allowed the participants to bring back formula to the store, excuse me, to the stores, even though they were purchased with benefits, and be treated as normal consumers in receiving any remedies for those items. We also asked for and received a waiver of maximum monthly allowance, which allows participants to receive alternate container sizes, including those that are bigger than usual and different forms like ready to feed. And we asked for a medical documentation waiver, which allows participants to receive a different brand of formula without a doctor's note, going away from our contracted brand of formula. Next slide. So additional changes implemented by Georgia WIC to help our families receive the formula that is available in stores, issuing benefits for more sizes of contract formula and 14 additional contract formula products, authorizing additional formulas, contract and non-contract brand, as well as store brands, making even more formula brands and types available to WIC families that can be purchased at the store when approved contract products are not readily available. Next slide. Formula supply is an evolving situation. Other strategies that we have undertaken, identifying areas with shortages as it impacts Georgia WIC participants and authorized vendors. Vouchers, we've moved to have vouchers that have single containers, again, as well as the availability of store brands and other non-contract formulas, and even donation of return formula to local community food programs. And that's a formula return to the WIC office, excuse me, as part of a food package exchange. Next slide, please. There are definitely some important reminders that we want to make sure everyone is aware of. Most families do have multiple safe options for their infants, even if their usual formula is not in stock. We remind families, if you can't find formula or can't find your baby's typical formula, work with your child's healthcare provider to determine the best feeding plan. Do not water down your baby's formula to stretch it out. Do not make homemade formula. Do not buy formula from online auctions, unknown individuals or unknown origins. Storage and shipping conditions may impact formula safety. We're also, as we are encourage breastfeeding in our WIC program, we also state that all women who are medically able should be strongly encouraged to breastfeed. And of course, WIC eligible families have access to an expert with clinical experience or training in helping breastfeeding mothers with complex breastfeeding problems. Next slide. So in summary, Georgia WIC is working to ensure that the program offers flexibility to WIC participants in obtaining infant formula. Georgia WIC continues to work closely with Mead Johnson to address areas with low stock as we make them aware through reports from participants, local agencies, local agencies and authorized retailers. And Georgia WIC responses to the shortages have included adding available formula for redemption, reducing the number of containers on a single voucher, allowing participants to obtain non-contract formula, including store brands, and donation of return formula to local community food programs. All right. And with that, we'll say, what questions do we have?
This is Kathleen. I just wanted to say I thought it was really important to demonstrate that in this, what is a national emergency around infant formula availability, that we were able to create flexibility within the WIC program to allow not only WIC participants to obtain formula, but also make it easier potentially for others to find formula, because we aren't buying up all of our contract formula. So I think this is an example of how we can legally bend the rules to maximize the flexibility to ensure the health and safety of children in Georgia.
Thank you for that update. This is Dr. Cheek, and appreciate it. And WIC, our local WIC representatives have been very helpful in our offices. Just wondering, I know that WIC provides breast pumps for new moms, but as some others have tried to reinstitute breast milk, has there been any thought of allowing breast pumps for women that are like further along other than just the brand new mothers?
So we have not undertaken any changes to the breast pump policy. It's something certainly we can take a look at. Thank you for that suggestion.
There was a question, were there areas or populations within the state that were more heavily affected? And I know, Sean, you said that initially we didn't see the kind of impact they were seeing in some other states around the country. Is it worse here in Metro? Would you say rural areas because they receive less infant formula? Kind of what is your assessment based on, the WIC inventory?
Thank you, Dr. Toomey. So it has been spots across the state. There hasn't been any reports of any particular areas that are more affected than others. What happens is usually when we receive a report, we will contact Mead Johnson and say, hey, there's a dearth of product in this area, at which point they will try to make sure that the formula orders for that area are increased and that the supply is restocked in that area. Of course, they're working with suppliers, not with the stores directly, but they try to make sure that, if it seems like the orders are down, they'll contact the suppliers and try and work with them to get that picked up. So one day we may have a shortage, and the next day it may be, somewhere else, while that area that was a shortage is picked back up. So it's thankfully, knock on wood, at this moment, it is no prolonged shortages that we're aware of.
Excuse me again, this is Dr. Cheek. Can you give me an idea of exactly, or a percentage of births in Georgia? How many of them are involved in the WIC program, percentage of new baby births?
I'd have to look up the exact numbers, but I think anecdotally it's about 40 to 50%. It's about half.
And I was going to say it's about half.
Yeah.
It is half.
It is, yeah, it is half.
It is half.
Mhm.
Thank you.
Welcome.
That was very helpful. Sean, my voice will turn this over to Dr. Toomey.
No, thank you so much. I really appreciate it. And I always learn from these from these presentations myself, even though I'm actively involved in the programs. I wanted to make one final kind of alert. You'll be seeing in the next few minutes that we'll be sending out a press release, and it has to do with the heat alert that's going on now throughout the state, not just in Atlanta, and the fact that heat can be deadly, particularly to the elderly, particularly to children. And just in anticipation of talking with you about this today and getting out that press release, I was shocked when I saw the deaths that have been reported related to heat-related situations, dehydration, syncope after overheating. Between 1998 and 2021, 35 children died in hot cars, which is shocking to me because I didn't realize the numbers were that high. But if you look at ER visits and discharges occurring across all of Georgia for all ages, it's even perhaps more surprising. You have not only deaths, more deaths than I had anticipated, but literally thousands of emergency department visits related to heat-related illness, heat stroke, other complications, dehydration, and surprisingly hundreds of hospitalizations. So looking at these numbers, I mean, there's just extraordinary health impact of this kind of weather after what was a relatively mild spring. And we're all thinking about hospital capacity. This is a significant impact on our hospitals as well when you have this number of people coming in with heat-related complications. And so I had asked our health directors to not only be aware of this and be, as they're doing outreach in the community, to be alert to individuals who may not have air conditioning, those who may be working outdoors because that's part of their job, who may be at higher risk for complications. So we will be getting that out in the next couple of minutes. But I think it's an important reminder that some of these not exotic things like monkeypox are also killers of people in Georgia and children in Georgia, and that we have to continue to be aware of this and take the precautions that we can take to ensure everyone is aware of this risk. So thank you, and that's all I have today.
Thank you, Dr. Toomey. Are there any other comments by the board or others? Do we then have a motion to adjourn?
So moved.
Second, anybody? I'll second it. We'll see you guys on July 12th.
Thank you.
Bye.
Bye-bye.